Hi, my name's Helen Williams. I'm a consultant pharmacist who specialises in cardiovascular disease, and I'm working with UCLPartners on their proactive care frameworks. I'm going to present the hypertension framework now. So these frameworks have been developed to help general practice to respond to the unprecedented pressure that they're experiencing as a result of COVID-19. UCLPartners has developed a series of frameworks that are developed by a clinical team of GPs and pharmacists, supported by input from patient and public, and are designed to work with local clinicians and their training hubs to enable them to adapt and deliver the frameworks within their context. Core principles of the frameworks are that care should be virtual by default, obviously where that's appropriate, mobilising and supporting the wider primary care workforce, which includes pharmacists, healthcare assistants, and other staff within the GP practice. Supports a step change in patient self-management, so empowering our patients to take responsibility and control of their care, and also including, where appropriate, digital innovations such as apps for self-management or technology to allow remote monitoring in the patient's own home. So the proactive care frameworks, embedding those principles, seek to stratify patients according to clinical risk, ethnicity, or other social factors into high, medium, or low priority groups, to allow areas to focus on the highest priority for early review, medium priority for phased review over time, and low priority patients where holistic care may be provided by non-clinical staff such as healthcare assistants, link workers, social prescribers, etc. But overall, allowing all of our patients within the clinical area targeted to be managed appropriately. So why focus on hypertension? Well, hypertension is the leading risk factor causing death worldwide. It's estimated that in England alone, there are 3.3 million people with undetected hypertension. And for adults under 80 years old, 2.2 million people who are diagnosed with hypertension who are not achieving the clinical blood pressure target of a blood pressure less than 140/90. We know the evidence suggests that delayed intervention for patients with hypertension for more than 6 weeks leads to an increased risk of cardiovascular events. And the framework that we've designed is to assist in remote monitoring of patients with hypertension, particularly important in the context of COVID-19, and the management of high blood pressure where required. So the frameworks will, as I've said, prioritise patients into different groups, and UCLP provides searches for EMIS and System 1 to allow you to identify these priority groups. The first priority group in hypertension is those patients with a clinic blood pressure of 180/120 or more. So this is the last recorded blood pressure in the notes. So we're trying to identify that very high risk cohort to allow us to check their blood pressure and see what intervention might be required. In general, the priority 1 group is a small number of patients for the average GP practice. Our second priority group are those with a clinic blood pressure greater to or equal to 160/100 or greater than or equal to 140/90 if there are BAME, if they're BME origin and they have relevant comorbidities or risk factors. And also the same priority group 2 group is those that don't have a blood pressure reading recorded in the last 18 months. And finally, one of our high priority groups, priority 3, is all those patients with blood pressures greater than 140/90, or if they're over 80, greater than 150/90. Those are the target cohorts for intervention by a prescribing clinician, because it's very likely these patients that had a previously uncontrolled blood pressure are likely, when it's retested, many of them will have, again, an uncontrolled blood pressure requiring intervention and possibly a medication. At any one time, however, there will be a large number of patients who are well controlled, possibly 50% of the patients on the GP register So the priority 4 groups are those that were previously well controlled. We would seek to get an up-to-date blood pressure, and if they remain uncontrolled, they'd be targeted for a conversation with a healthcare assistant or other staff role. And that healthcare assistant, social prescriber, wellness champion, whatever their title is, would have a script to support them through reviewing self-management, behaviour change, identify if there are medication issues, flag them to a pharmacist if necessary, advising patients on when to submit their blood pressure readings in future, when to seek help if they take readings that are high, and also identify if there are red flags that need referral to the GP. And all of that is included within a protocol to support these staff. As I've said, those in groups 1 to 3 are likely to need prescribing intervention if their blood pressure is still raised, and the prescribing clinician would take them through appropriate monitoring, reviewing the medication they're on, referring where appropriate, and again ensuring that they know when to take blood pressure readings, what to do with the results. And this cohort would need follow-up again to see how effective the intervention to control their blood pressure has been. But the same group of staff, HCAs or other non-clinical staff, could focus for this group on the self-management and behaviour change and coaching patients through that area. So a comprehensive approach to all the patients on the hypertension register, allowing clinicians to focus on those at highest risk and non-clinical staff to support those that don't need active intervention, but do need a discussion about lifestyle, etc. So when we talked about comorbidities and risk factors for patients who were from Black, Asian or minority ethnic groups, we're talking about those with established cardiovascular disease, so prior stroke or TIA, pre-existing heart disease, so maybe they had angina, they might have had a myocardial infarction, or they may have had cardiac intervention like an angioplasty and stent, or peripheral arterial disease. Those with diabetes, those with CKD3 or more, and those who are obese with a BMI greater than 35. These would put these individuals at higher risk and therefore move them from the priority 3 group to the priority 2 group for earlier intervention. One thing that's really important to remember is that home blood pressure readings, where we use home blood pressure readings that the patients recorded themselves, tend to be lower than clinic readings. So we need to adjust our thresholds downwards. So for example, a blood pressure of 140/90 in the clinic would equate to a home blood pressure reading of 135/85. Or a blood pressure of 160/100 in the clinic would equate to a blood pressure less than of equal to 150/95. So slightly lower. It's important when we're treating people that we treat, if we're using home readings, we treat to a slightly lower treatment target. So the aim of the pathway is to really see if we can get blood pressure results back from the patients using their own home blood pressure monitors. We know that 30 to 40% of patients already have access to a blood pressure monitor at home. So practices could contact patients, possibly by text, to say, have you got a monitor? If they say yes, over time we can check whether it's a validated monitor, whether it's within a reasonable age. So we aim for them to be less than 5 years old. We know that these monitors are then accurate for home blood pressure monitoring for up to 5 years after purchase without calibration. We also need to check over time that they know how to use the machine properly and how to check pulse to see if they have any underlying AF. But if a patient has a blood pressure monitor, the aim is for them to start submitting their home blood pressure readings. If they're substantially different from their previously recorded reading, then they may move between the priority groups as a result. If the patient has no blood pressure monitor, ask if they can buy one and give them their links so that they can buy an approved validated device. Or maybe there may be a local service to provide a blood pressure monitor, and there's also some national scheme to improve access to home blood pressure monitors. And if the patient can't get access to a blood pressure monitor or doesn't want to home monitor, then we need to think about face-to-face options. A further thing to consider is patients who have AF or who have an irregular pulse. We might need to think about doing multiple readings to get an average blood pressure that's accurate using automated devices at home. So validated devices are linked within the framework, so you can see which ones are recommended for patients for home use. We generally prefer upper arm blood pressure devices in terms of accuracy. Patients don't need to spend a lot on blood pressure machines. There are some devices out there that cost well over £100, but a basic model is suitable as long as it's on the validated monitor list. Important to ensure the patient has the correct cuff size to get an accurate blood pressure. And while Bluetooth connectivity is nice to have, it will allow the automatic transfer of data into a patient-held device, such as a smartphone. We do have the problem at the moment that these NHS can't necessarily interface with all these portals, and obviously a Bluetooth-enabled device is more expensive. So it's down to what the patient can afford, and as I say, a basic model will suffice. In most cases. Talked about the fact that we will obviously identify patients who have an irregular heart rhythm if we encourage patients to check their pulse rhythm. It might be then that they need follow-up in the practice or in a community setting or through open access ECG at a local acute trust. There are technologies you can use to see if this irregular pulse is likely to be AF, such as the device FibriCheck, which uses the patient's smartphone camera and flash to do pulse wave analysis and will assess whether the pulse rhythm is regular or whether it could be AF. And then there are other single lead mobile ECG devices, for example, Cardia by AliveCor. Again, the patient needs a smartphone, My Diagnostic or Zenicor. So signposting to different options in order to identify whether the irregular heart rhythm is likely to be AF. As I've alluded to, it's quite hard using automated machines to get an accurate blood pressure in people with AF. And even those devices that are AF detection blood pressure monitors are not validated for assessing blood pressure accurately if people are in AF at the time. So there are two options. One is you can take multiple readings, so 2 readings, morning and evening, over 4 days and average them all. So you'd end up with 16 readings. And in this way, you'd get a more accurate assessment of blood pressure in AF. Or you could book the patient in for a face-to-face manual blood pressure check, which is what we would routinely do. If the patient presented to the clinic with AF, we would use manual SFIG and stethoscope to check the blood pressure. So there are resources, there's a number of resources within the pack, a summary of some of the solutions that are out there that can transfer the blood pressure reading from the patient to the GP practice electronically, and each of them have strengths and weaknesses, some have costs. So we've looked at 5, this isn't exhaustive: AccuRx, eConsult, Omron Connect, Omron Hypertension Plus, and Primary Care Pathways. Local areas will find that they will also have access to providers that can help with this particular issue, and will need to assess their suitability for local use. Some of the remote diagnostics we've looked at, as I've talked before about FibriCheck, which is a pulse wave analysis to see if patients may have AF, the mobile ECG technology, and also Healthy IO, which allows home urine testing for albumin creatinine ratio, so is useful for patients to assess renal function. Lots of resources for patients are out there. The British Heart Foundation has developed a hub for people checking blood pressure at home. All the advice, the links to the approved devices, etc. are there. Similarly, the Stroke Association has information for patients on high blood pressure. We've got videos, tutorials on how to measure your blood pressure at home, diaries, as I've said, validated BP monitors, and advice on how to choose the right monitor. And then similarly, the same sort of information for people with irregular heart rhythms, so assessing pulse rhythm at home, including videos, fact sheets around know your pulse and what an arrhythmia, an irregular heart rhythm might mean for you. In terms of management, whether the blood pressure is taken in the clinic or in the home environment and fed through to the practice, the management in terms of medicines and lifestyle is very similar. So really linking people to the NICE recommendations around drug choice to support intervention with medication. And finally, just a note that there is support, implementation and support available through UCLP. The searches that are on the system for EMIS and System 1 are available to download to support the prioritisation of patients, the identification and risk stratification within those priority groups. The framework is available, and all of these tools and resources that I've just taken you through. So thank you very much.